Hi, and welcome back to another episode of Ask Clever Over Coffee, How AI Built This. I am your host today, John Marino, and I am joined with my co-host, ChatGPT. The voice is Billy Darkenweld.
Hi there.
Hey.
Be here.
And we have a special guest with us that we're super excited about, and her name is Eve Cunningham. And she is the Chief of Virtual Care and Digital Health from Providence. Hi.
Hi. Thanks for having me.
We're super excited. When we came up with this concept for the podcast, one of the most important parts was to really talk to people who were using AI in different industries and talking about the challenges and the successes and what it looks like. And looking at what you guys are doing at Providence Health, there is so much to cover today that we are just so excited to dive right in. And then we also know that August 12th through the 14th, you're speaking at the Ai4 Conference in Las Vegas. And we're going to cover a little bit more so people who are attending the conference can kind of get like a brief intro into what you will be covering and what to expect at the conference as well. So let's get into it.
Sounds great.
Yeah. So at the Providence, could you walk through with our audience just a little bit more of like the intro of where you guys have started in your timeline of introducing AI into Providence and a little bit more of a high level of what you guys are doing there?
Yeah, and before I do that, I just want to give a little bit more background on like my role at Providence. So because sometimes people Providence is a $28 billion, 7-state, 52 hospital nonprofit health system on the West Coast. So we have a very large organization. And so I just want to kind of share a little bit about where I fit in the broader organizational structure. So I lead virtual care and digital health at Providence, and I'm an OBGYN physician by training, and I still practice a little bit. In my org, we almost act as like a center of clinical innovation, clinical transformation. So we drive a lot of initiatives across the organization, specifically around clinical care delivery. So direct patient care around how do we start to innovate in that space? How do we start to bring things like telemedicine, digital health applications, AI into the clinical spaces? And how do we do that in a thoughtful, safe, meaningful way so that it's really, we're measuring that impact of care? And so within my portfolio, within my team, we have over 9 enterprise telemedicine programs for hospital to hospital specialty consultations. We have a hospital at home. We have remote patient monitoring programs. We have ambulatory virtual care programs we support. And then we also have digital products. And so we have some digital products specifically designed to support clinicians at the point of care. And MedPearl is one in particular. I know we'll probably talk about that one a little bit. And then in addition, I co-lead the clinical AI governance work group. And so your question specifically was around like, how is Providence approaching AI? How are we looking at it? So I think every health system, now that generative AI has been released, and so there's always been discussion about how AI and automation can help clinical care. But with the release of generative AI and all the possibilities of what we can do with that technology, I think every health system is kind of thinking about like, how do we bring this in to our space in a meaningful way, in a responsible way, and how do we start? And so what happened last year was that we stood up an AI governance structure. And so there's like an overarching AI governance work group. And then within that, there's some pillars. And one of the pillars is specifically focused around clinical care delivery. And so that is the space where my team, where I co-lead this with one of the leaders. She leads strategy on the IS side of the house. Together, we co-lead this work group. And then within that, we evaluate different use cases. We evaluate different vendors or different solutions and how they could impact care delivery. We got to start somewhere, right?
Absolutely.
So we start to prioritize where those use cases might be helpful and start to implement. And we can go into more detail around what our thought process and evaluation process is for that.
Sure. Yeah, there's always the start, right? And a lot of people, when they're getting into AI and using it for the first time, there's, you kind of like crawl before you walk, before you run. And with that, people are learning about, prompt engineering and just talking to an AI bot. And what does that look like? What does it sound like? In healthcare, there is a lot going on. There's a lot of layers that have to be thought about and discussed before you're even like using an LLM within it. And what was some of the key points or problems that you guys were looking to solve when you started this direction with AI?
Yeah, I mean, I think, and I don't want to speak for like everything. Like I can't speak for like what the rocks and the shoes are for the HR team,
sure,
right, at Providence versus like revenue cycle. I mean, there's
right.
many different components and aspects of a large, healthcare operation. So I'm going to focus more around clinical delivery.
Okay.
So when we talk about clinical, we have to be extremely, extremely careful.
Right.
So I'll give you an example. Like we use Microsoft Copilot. We have a big pilot going on with that where we can use that for administrative purposes, right?
Okay.
I mean, the risk if you have a meeting, it's listening to the conversation during the meeting and then it spits out like a summary, and if it gets something wrong, it's not going to hurt anybody, right?
Sure.
But when it comes to patient care, the tolerance for an error, right? For a hallucination, for something to come out that's not exactly right is pretty low.
Okay.
And so the bar has to be very, very high. So the application of especially large language models and generative AI into direct clinical space is going to be a very slow and incremental process.
Sure.
And so the way that we've started to experiment, first, it's just more like education, understanding what the technology can do, learning about what research is going on, shared learnings within the system, a lot of prototyping and just sort of but like experimenting with things, but not actually bringing it directly into patient care. So I would say that there's a lot of that activity going on just across the industry. We have a lot of peers and other institutions. There's some consortiums that are coming together to kind of evaluate how we're looking at that. So I think that's a lot of what's happening right now, that there's not like this broad like application right into the clinical space. But then we do have some areas that we've started to really apply AI. And I think it's really important for people to understand that it's not like a one size fits all and we're just going to throw this thing into the clinical space and it's like going to do everything. Like
right.
It's going to be little pieces of care that we're going to be able to bring this technology into the space. And so for the clinical AI group, what we did was we first sourced a lot of feedback just from like end users, clinicians, like people who were delivering care that had ideas. And the areas that we're really prioritizing, I would say, are areas that can impact workforce burnout, administrative burnout, workforce shortages, so creating efficiencies. And first, even just supporting like administrative functions that maybe don't have as much clinical impact. And then moving beyond there on looking at areas where we can optimize quality, right? Or augment the clinicians so that we can support them so that they can better manage the massive amount of information and knowledge for which they are responsible. Okay. And then there's some other areas like around like, how do we leverage this technology to help us improve our communication style or help us having difficult conversations with patients. So those are kind of like from a clinical perspective, I think those are some of the areas that we're really starting to hone in and drill down.
Got it. And when you are talking about the kind of like going slow, making sure you get it right, putting it in a testing environment before you're introducing it into clinical patient care, I was thinking about like this, you have two parts in healthcare, right? One is that healthcare has really been known for all the admin that goes along with the care, and it can be a lot of red tape, or it could be a lot of cumbersome duplication in a lot of different departments. And when you guys are looking at using it in a clinical environment, are you looking at automating some more of that so it increases the productivity overall of a practice?
Absolutely. And I would tell you that in some cases, you don't need an LLM or generative AI to solve the automation challenges.
Sure.
I mean, some of it is just like straight up like intelligence. I mean, some of it is just like straight up like, how do we clean this stuff up?
Sure.
How do we create logic, decision trees, and things like that, and program it and just prioritize it. And some of it is like, hey, we need better technology to do this. So like, I'll give you a couple of examples of things that we're doing at Providence. For example, we have been using ambient dictation for almost 4 years.
Okay.
So we were one of the first healthcare organizations to use DAX, which is Dragon Ambient Technology, Dragon Ambient Experience, which is a nuanced Microsoft product. And so basically what happens, I'll just give you I think we're all patients here. I'm a doctor, but we're also all patients. And so we've all experienced like going into the exam room and the doctor like pulls out the computer and they're like sitting at the computer and staring at the computer and not looking at you because they're trying to capture everything that's happening.
Right.
So there's a huge amount of promise with the concept of ambient technology. I mean, for me as a clinician, I hate the fact that I have to spend, several minutes every patient, sometimes 10 minutes every patient writing my note. Wouldn't it be great to use an ambient technology to write my note and structure it for me, and then I just have to do the review?
Right.
So we started out about 3-4 years ago, and it was rough in the beginning.
Okay.
It was early stage, product.
Yep.
But it's really evolved.
Okay.
And matured quite a bit. And so we have one of the largest deployments of DAX. There's other vendors that are doing similar things out there for physicians they're doing quite well as well, and see a lot of promise with, being able to just walk in the room, have your conversation with the patient, have it captured, documented, and then you can add whatever other things you need to add. So that's one area where we're using AI, and there's been a lot of research, a lot of validation, and then there's always still a human in the loop in the sense that the clinician still reviews the note and approves the note or makes modifications. So we're still responsible for making sure the quality and the accuracy of that note is appropriate, but definitely have been able to demonstrate improved efficiency, reduced burnout, reduced after hours time doing documentation. So very impactful solution. Another area that we've been, and I can't take credit for DAX or for the next one I'm going to tell you about, because it's not me that did the development or sponsors that program, but huge cheerleader on the sidelines for some of these initiatives, is a project called Prov-Aria, which is essentially, since COVID, happened, more and more patients have started to log into their patient portals, which is great.
Yes.
That's a great engagement strategy. They're digitally trying to connect with their clinicians.
Right.
But the problem that has happened as a result of that is that patients are now so comfortable messaging their doctors through their apps and their portals that we have seen an exponential increase in the number of messages we have coming into our inboxes.
Sure.
To the extent that doctors are so overwhelmed with the number of messages, they cannot keep up.
Sure.
And sometimes patients think this is like a chat feed or something, and we don't get compensated for those exchanges.
Conversations,
okay?
right? Yep.
Yeah, I mean, they're working on trying to find a way, and I mean, there is like this e-visit thing, but it's really hard to meet the criteria. It's just like we don't have enough time
Sure.
to like
Right.
even deal with it, and the electronic record isn't really well positioned at this point to allow us to provide the care that way in a billable fashion. So what's happened is you have massive amounts of messages coming in, and we put these nursing teams in place to kind of like filtrate the messages and look for like this one's. And so what's happened though is that like a nurse might come in and there's like 1,000 messages waiting, from the last couple of days that they're needing to triage, and there's no prioritization.
Sure.
Meaning the message number 500 could be a patient who says, I'm having chest pain, or I'm feeling suicidal, but we have to get through this queue and there's no prioritization of the queue.
Sure.
So what we've done is we have developed a large language model that can consume all of the messages, understand the intent a little bit better of the messages, help prioritize the ones that seem to be more concerning. So we've trained the LLM to sort of identify those, and then provide some suggestions on some next steps. Now, the nurse is still in the driver's seat. The nurse is reviewing, the nurse is deciding whether or not this really is a more urgent message. But what we've been able to do is significantly increase our ability to process these messages more rapidly. So improve the productivity of those nursing teams that are now processing these messages, prioritizing the messages, and then significantly reducing the anxiety, concern, fear that the clinicians feel, that the nurses feel that like they could miss something or something could get delayed in getting addressed, because it used to be like, this one came in at this time, you do that one first, this one next, this one next. It was all time-based. And now it's more prioritization-based, based on like what the intent is, what the sentiment is, and like whether or not this seems like something that needs to be more urgently addressed. And then the last thing that we're doing is around MedPearl, which is a digital assistant and clinical content management system. It's like a clinical intelligence engine that we've designed for clinicians by clinicians. And basically what this is if you can imagine, we are completely overwhelmed with information as clinicians. Medical knowledge doubles every 3 months. And the patient's charts, the digital patient chart of today is like a 200-drawer filing cabinet against a wall filled with papers.
Yep.
It's just a massive amount of information. We cannot consume patients' charts. Like there's just way too much information.
Sure.
And so when we are seeing patients, we struggle with finding the things, the insights within the patient's charts that we need to make really good decisions and to apply the knowledge that we need to be responsible for at the same time. So MedPearl allows us to collaborate and create in a no-code environment digitally consumable clinical content to provide next best actions and guidance at the point of care around specific conditions, and correlates that content with the relevant patient data in the patient's chart, so that we're seeing the knowledge and the patient data in a very consumable fashion at the point of care to supercharge our decision making. And what we did from an AI perspective, we still have very human-centric curation and creation of this knowledge because it's supporting clinical decision making.
Sure.
We need to make sure that there are clinicians really heavily involved in the process, but it's a foundational layer in which we can start to build in AI tooling to augment and accelerate that content creation process. And so we layer in to the content creation and delivery process different aspects of AI that help supercharge or help to better develop that tool. For example, search optimization, primary source verification optimization, research, bibliographies, and things like that. So we're using AI to supercharge the content creation process, and eventually we hope to move to a place where there's more automation of that content creation as we train models to do that over time.
Sure. You have covered so much in that long-winded answer that both of us have questions, ChatGPT and myself. But I will let ChatGPT go first, and she's got a question for you.
A lot of great information. I just wanted to go back to Provaria. Is that how you pronounce it? Provaria?
Yeah.
And it seems like it's a great tool that's going to be making huge efficiencies within the company. But are there any hurdles that come about with implementing this tool on the Provaria side?
Yeah, I mean, I think you cannot underestimate the challenge with change management, in the clinical space. But this one has actually been a huge winner. It's a pretty easy one. Well, all three of them have been pretty easy to implement. That being said, we've still had to do a ton of change management, socialization, getting buy-in, getting people to understand. I would say that I think a couple of challenges with the implementation of Provaria, and I can't speak to everything because I wasn't there, but we specifically focused around the nursing staff in particular with that particular use case. So what we found is, Providence is a 7-state. We have over 1,000 clinics in Providence. And so it works the best when you have a centralized nursing team that manages inboxes for physicians across a broader population. So not just one nurse by themselves with one or two physicians. And so we found that some of the deployment was hindered by the fact that operationally, not all of the back offices had that specific workflow in place. Mm-hmm. So we really focused in on the geographical areas where we had, large teams of nurse triage teams first put in place, manually kind of going through these messages. So they kind of already had that structure in place. The workflows were put in place, and then we layered in the technology, and it really just took off. So some areas we couldn't do the deployment until they reorganized their back office to support that workflow. And then once we were able to do that, then we were able to start to scale more broadly across the system.
What did that timeline look like as far as them reorganizing?
I think we've been on this journey for about 1.5 years. I think they really made the commitment, though, to start to scale, I want to say it was about 6 to 9 months ago. So they really had to do some preparation to reorganize, because again, if you're going to start to reorganize the way your back office works, there's a lot of change management involved in that, even though you're not even bringing technology and you're just reorganizing the work, and there might be some funding requirements and things like that. So those are the things that you have to take into consideration before you do an implementation like that. Yeah.
So going back to the earlier part when you were discussing about all the communications that come in, and when people are talking to a doctor, almost like what you were describing as a chat feed, where they had these questions and follow-up questions, so I am a parent. I have a 5-year-old and an 18-year-old. And I know sometimes I have questions that I feel are pretty basic, like, hey, is this important to come to the clinic? Should my son come see the doctor? Is this bad or is this okay? Or what have you, just kind of the basic questions. And I know right now my provider has an online chat forum where you can go in and ask kind of those questions, or you can call the Ask a Nurse line and just ask those basic questions. Have you and your team looked at using AI to facilitate questions, whether it would be like via text or it would be an online chat form? Like our company, we've really worked a lot with AI voice, where people can talk on the phone with the AI and have all sorts of different conversations. And I've been working to learn how to train the AI voice to answer those questions, which is taking a lot of effort as well. But I'm kind of interested to learn more about when you guys have an inundation of all of these conversations, and then the AI for sure can prioritize based off of the, your training of the model. How has that worked? I mean, are you seeing success with it? Do you score? Is there an AI score that you give for each conversation, and then you look at it that way? How is it working?
Yeah, so I guess I didn't talk about there is another use case. It's not clinical yet, in the sense that the functions of the bot does not do a lot of clinical stuff at this point.
Okay.
But we do on the front end of, we have an app. Providence has an app. We have like, I don't know, 500,000 plus users of our digital app. And then within that app, there's a bot called Grace that we've had for a while. So we've been working on this project for a little while. And Grace is designed to do exactly what you said, like try to answer simple questions, triage them, get messages that maybe don't need to go to the doctor's inbox, get them to like the front office, or, you know, triage them to different places so that we're not overburdening that physician inbox.
Right.
And so so I told you the back end, which is the Provaria project. On the front end is this bot who's kind of saying, hey, how can I help you, right?
Sure.
And so most of what she does today is more focused around like, you want a medication renewal, refill, and you already have it in your, you know, in your chart and everything. Let's just go ahead and get that done.
Sure.
So that we don't have to like bother the clinicians or bother the clinical staff. Oh, you need a referral. Let me gather some information and then pass that off to the clinical team to evaluate, or to the referral team.
Right.
Oh, you want a visit? Let me get you scheduled for a virtual visit or something like that. So definitely already starting to do some of that. And we have metrics that show message deflection rates and the number of messages we're able to deflect as a result of that, to unburden the inbox. I think the problem is that it's like a faucet that just like keeps like expanding and growing and growing. So even deflection doesn't reduce, because it just continues to expand, because that's the way patients now want to communicate. So yes, we imagine a world in which, and this is part of what we're sort of trying to work on, but at a very early level still. Yeah. You know, they have these symptom checkers. My experience with symptom checkers, there's many of them out there, and I'm a specialist, so I'm probably a little biased. But number one, I've gone through them multiple times, and sometimes I'm just like, really? This is what we're recommending? This is what we're asking? It's almost like, and I don't want to like diss on them, but like a lot of them are not very useful. Okay. Or it's like, I'm going to ask you 15 questions and go see a doctor, right? I mean, that to me, that's, as a clinician, that's not useful. What we are working on is, let's ask you some questions, and then based on your symptoms and the questions that you're asking, here's some education. Yep. That could be one thing. Here's a recommendation. Actually, you should have a virtual visit. This qualifies for a virtual visit. It's clinically appropriate for that. Or this is clinically appropriate for an in-person visit. We recommend that you go to an in-person visit. Or this is clinically appropriate for you to see a specialist, okay? Because a lot of times they have to go see a doctor. It's usually a primary care frontline, and then they still have to see a specialist, okay? Sure. Well, there's a lot of times where maybe they don't need to even see the primary care, or, you know, they meet criteria where it makes more sense for them to get into the specialist. And there's just like, it's like massive gatekeeping process that's months long from an access perspective to get them in. So how do we get people to the most clinically appropriate care? Or, hey, this isn't something that needs to get you to the ER. And then from a clinician perspective, being able to know, like, hey, the patient had this chat, it was determined it was clinically appropriate for them to go to X, and I'm going to communicate that information to you, clinician, or to the clinical team, so that they can pick up that information and move forward where it was left off. And so it's what we're imagining is, like, right now the problem, we don't have enough doctors, okay? There's not enough access to care. It's going to get worse. It's not going to get better. It's going to continue to get worse, because we have 10,000 patients aging into Medicare every day. Yep. I mean, the average wait time for some of these specialties, like in the Pacific Northwest, to see a neurologist is like 4 to 6 months. Oh, wow. Okay. So how do we drive the most clinically appropriate access? Because it's not about just access anymore. It's not about just getting in to see a clinician. We all have different varying levels of expertise and capabilities. It's matching the clinician to the most clinically appropriate care delivery mechanism, whether it's chat, virtual, in person, emergency, whatever.
Right.
And then with the right type of clinician as well. So we're driving the most clinically appropriate care. And we envision a world in which we can help patients self-serve that better by providing them with that guidance with clinical tools like an AI bot. But we're a long way from there. We've still got work to do. But that's what we're working towards. On the back end with MedPearl, we're providing that guidance to the clinicians to help that with their patients. And then how do we start to translate that to patient-facing so they can self-serve, right?
Yep.
And better navigate themselves through the system.
When I'm listening to you, and there's a lot of different use cases of how AI is being used, and you brought up some good challenges. There's a lot of stakeholders within the care of a patient, and when you guys are using AI or developing an AI tool, can you walk us through a little bit more of like all the different stakeholders that are at the table that have input? Like, for example, like what you were just talking about, where somebody's trying to navigate the system of care and trying to see a specialist or somebody that they need to see. Who is all involved on the back end to help the AI model navigate all of that?
Yeah, so I would say that foundationally, just at the front end, at the very front end of the process, you have to make sure that you have safety, ethical, privacy, guardrails, right? So security team, like ethics team, like even just like at the very, front end of that is just be like, hey, number one, we have this use case. What are some of the considerations we have to take into place before we even start down this path and this journey? Because you might be able to ideate, but like we really need to think about how we do this in a thoughtful way. So I would say foundationally, like, I don't know if every single thing before like something even just gets starting to like experiment with has to go through specifically through that, because it's not going into production yet.
Right.
But it's like, hey, these are the guardrails in place.
Right.
Before you even start.
Right.
Okay. And foundationally, this is where you're going to go. So they've kind of like laid that down to say, okay, and then if you're going to go any further, you've got to go through this process of evaluation and assessment of that. So I would say that that's one of the things that has to happen very initially. And then to your point, we have a lot of engineers, technologists, people in operations. They want to make care better. They're not clinicians. They don't take care of patients. They don't have clinical expertise. So historically, what had happened with a lot of this stuff was that it was being talked about, sort of trying to develop it, and like clinicians were like consultants on the side. I think they've come to the realization that clinicians have to be like heavily engaged and involved in the process.
Right.
And so I would say a lot of the, especially more clinically focused, anything that's clinically focused is being led by clinicians. And there's almost like this new generation of clinicians where we're not just like the people that used to be involved in clinical technology were mostly just like informatics people or people who had an informatics background. And what's evolving is that you now have clinicians who have worked in health tech or have product development experience or even have engineering degrees. So there's like this like new generation of clinicians that are coming forth that are experienced in clinical care and clinical care delivery. So Provaria, for example, the two physicians that have developed that solution, they're doctors that take care of patients and they're engineers and they can write code. So they can kind of imagine how you can create the solution both from a clinical perspective, an operational perspective, and the technology perspective. So there either needs to be a very close collaboration between clinical people who understand clinical operations and clinical workflow and the clinical expertise with a technologist, or you actually have this integration of clinicians who are also engineers and deep into the technology.
Yeah, I mean, both of those are extremely valuable, and it's interesting that you would even have clinicians that have that technology expertise. ChatGPT, I know you have a question.
Yep. So ChatGPT was reviewing one of the articles. Correct me on how saying this. Is it Solace or Exalis?
Do you know that program? Exalis?
Not familiar.
Okay.
Not familiar.
It said Providence and Exalis said the tool helped reduce observation length of stay by 32% in its first 8 months.
That is not one that I am familiar with.
Okay, we'll edit that one out there.
So that's probably an inpatient focused tool. I know they're
Okay.
also using Lean TOS. I could talk a little bit about what they're doing for Lean TOS, but
Sure.
but I'm not sure about Exalis. I haven't heard about that one.
Okay.
But we have some AI initiatives happening, like in value-based care, in like inpatient operations. So I don't know about every single thing, but that's interesting that I wouldn't know about that one.
No worries. We can move on from that.
Well, I know, like, since we're moving into the headlines, can you talk a little bit further about Providence's partnership with Microsoft, and how is that working with the collaboration in developing the tools? Is that going well, or is there bumps in the road, or how's that working?
Yeah, I mean, we've had a partnership with Microsoft for about 5 years.
Okay.
Maybe 5+. I think maybe we're going into year 6 soon, and it's been great. We're super lucky because we're based out of Renton, Seattle area, so we're really in a tech hub,
Sure.
which is a great benefit to us as a health system. So we started. I would say that Microsoft has been pretty significant in influencing my career trajectory. So just our partnership with them in particular. So just to give you some background, I didn't come from technology. I am not an engineer.
Sure.
I don't have an engineering background. I don't even have a technology background. I came from clinical leadership. So practice medicine. I still practice a little bit for many years. Took over like as medical director, leading a large clinical team eventually at Common Spirit, and then moved over to be a chief medical officer of a medical group at Providence about almost 7 years ago now.
Okay.
And when I took over that medical group, I was leading clinical operations. So we had about 40 plus clinics, 25 specialties, 350 docs that I was leading. I wasn't doing anything necessarily technology, but I was always trying to push my clinician peers to think differently about how we deliver care. Like the standard 20-minute office visit, yes, those are necessary interactions that we have to continue to have, but that should not be like the standard of how we deliver care.
Okay.
There are so many other ways for us to deliver care, and we need to think about how we transform that and deliver it differently. And so what I found though was that my clinical peers, especially during COVID, when everything just like ripped the Band-Aid off and we're doing virtual care, we're
Right.
delivering care differently, but people were really frustrated with the technology experience that they were having. And we had this big fancy partnership with Microsoft, but like all the technology that was being developed wasn't really translating to improve the experience of delivering the care to the patients.
Okay.
So we just didn't really have a voice in that partnership because there weren't really physicians on the front lines that were involved in it. It was happening at the, high level corporate level. So I kind of like hustled my way in, convinced the corporate development team that they needed a physician on their team for corporate innovation, and joined their team as their chief medical officer. That was about 3.5 years ago. And one of the things that they assigned me to do was sort of to be the clinical liaison for Providence with the Microsoft partnership. So I met a ton of the folks from Microsoft. We did some little POCs and, MVP, like little tests of change and experimented. They were learning too, because they didn't really understand healthcare.
Right.
And then we were learning more about technology. And I learned a lot from working with them. And, the product that I'm now the founder of, MedPearl, the genesis of the idea really came from early engagements with them, us talking about a problem that we had, and the Microsoft folks saying, well, maybe you should think about solving that problem in a different way. And here's how maybe you should think about technology and how it could help you solve it. They've influenced, I would say, the organization in a good way. They've moved us forward in a good way. We enjoy many of their applications in our health system. We think about different ways that we can collaborate together. And there's many other collaboration points, but they've been heavily involved in supporting our corporate innovation strategy. And I think it's been a good partnership so far.
That's great. That's great. When you talk about communications, and it's great that you are the liaison for the clinical side with the technology experts. I think a lot about communication myself. And when I go to a doctor, and I have met with a few different doctors, and some of them, what I notice is like my own inherent biases on some of the different scenarios. For example, because we've talked about this on the show, like if I have a really old doctor that I'm meeting with, or a very young doctor who's brand new, I noticed myself that I seem to question the doctor more, or give it more scrutiny. And then when we've been talking about AI in other episodes in matters of healthcare, when it comes down to communications, you really train it so you don't have the same biases. Like if it's the same tone with every single person and it doesn't really matter, they don't react, the AI doesn't react to any perception of how you're being communicated with. It's just trying to answer the questions based off of the training model that it's been provided. The question that I'm having is that when you are training the AI, what process have you guys gone through to kind of curb any biases, on race or age or sexual identity or what have you? What have you had any issues with that in the training models?
Yeah, I mean, I wouldn't say that I can't. So from an administrative perspective, like, some of the areas, like I talked about the bot that was in the digital app, obviously there are some fine tuning that they've done. I can't speak to all the specifics of how they've done that and everything. Sure. I want to just be pretty clear that we're not at this point, the different use cases that I've given you, we're not using it to actually directly provide clinical guidance to patients at this point. Okay. Because of what you're talking, because of many reasons, because there's hallucinations, that we still need to parse out, because there is risk of bias, right? Mm-hmm. And I think a lot of the training that's taking place is trying to figure out how you formulaically build that fine tuning in it, how you test it and pressure test it. So there might be some applications in there that can address those particular issues with a specific use case. Mm-hmm. But when we talk about broadly using it, I know there are companies out there that are broadly just releasing it to the world and just letting it happen. We're in our particular situation with our health system, and that would be a huge liability for us on our part. We can't quite do that yet, and so we have to be super careful and responsible about it. But I wouldn't say that there's a secret sauce yet of this is the way that you eliminate bias. You know what I mean? Nobody knows how to do that completely from an entire model. Right. But having that as top of mind as you're evaluating the solution, and testing it, and then it's going to be a very research-oriented incremental process as it continues to start to integrate into care delivery. Okay. Yeah. ChatGPT?
Yes. So, Evie, I was looking through ChatGPT just regarding some questions of, you were still said you are an OBGYN, and now your title's changed to Chief of Virtual Care and Digital Health. What was the biggest challenge in transitioning from direct patient care to a leadership role in technology?
Well, I didn't go directly from patient care to technology. Okay. So I had shared that first I went into clinical leadership. Mm-hmm. So when I went to become a chief medical officer at Providence, I actually stopped practicing for about a year. I had gone from, practicing full-time, full scope OBGYN, then dropping OB in 2016. And I would say that was a bittersweet decision because, I delivered thousands of babies and had these amazing experiences with women for so many years. And it was really hard, but I had 3 young children, well, 2, and then a third on the way. So, a family that was growing. My husband's a surgeon as well. We were both taking a lot of call, and it wasn't like really conducive to really being able to be present for my family. If we were both doing this full clinical practice, it's just hard, So moving into leadership was sort of a natural progression for me, and it was very rewarding. Not a lot of physicians, like leading physicians is not always the funnest thing in the world. We are not easy people to manage, okay? And we don't like being managed. We're very strong, independent-minded people. We have very strong opinions. And we obviously want to be well compensated and well treated for the work that we do under the conditions that we work under. And I don't know, I just had like a knack for kind of inspiring and growing people and building good teams. And so moved into that. And so I was leading the medical group, as I told you, and about a year into that, when I wasn't practicing, I felt I think one of the hardest things was giving up surgery for me, and it still is, I stopped operating, and I had been a robotic surgeon and done all this cool stuff. And I got invited to go on a medical mission to Guatemala about a year after I went to work for the medical group. And I don't know, just something in me told me that I needed to go. They needed an OBGYN to assist the primary OBGYN that was going to be doing surgery. And I went down there, and we just spent a full week, just filling our cup, seeing patients there was no electronic health record or technology or anything down there. I mean, there was surgical instruments and things like that and anesthesia, but it was just very like just the pure core, just let's just take care of these people who has been waiting months, almost years sometimes, to have their surgery. And after a week of doing that and just really just feeling like just super pumped about spending time in the OR, spending time with peers, making patients happy. When I came back, I said, I need to do some clinical practice. Like I can't just completely stop practicing. Like I feel like something's missing. And so I knew I couldn't do primary surgery anymore because to have a surgical practice, you can't be operating, once or twice a month. It's just not good for patient care from a quality perspective. It's not good, like from a continuity of care for patients. It's not friendly to your peers and colleagues. But what I did do is I said, I'll see some clinics. So I see patients in clinic a couple times a month. And then I scrub in and assist in surgery, a couple times, once or twice a month. I'll try to do that. And it's great because the surgeons love having an OBGYN as their assistant because, it makes it really easy and quick. And so it's a win for everybody. Then when I moved over to the corporate development team and then eventually took over virtual care and digital health, I've continued to do that. And I have several physicians on my team, and I encourage everybody on my team to continue to do some amount of clinical practice. I feel like it keeps us very grounded and connected to the work. It helps us understand the workflows and the experience of the technologies that we're using. And it gives us a lot of street cred when we're going and talking to our peers and say like, well, yeah, I saw a patient last week and, blah, 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 this happened. Like, they're like, oh, you still see patients? And it's like, yeah, man, I'm down there, in the trenches with you. And I'm there with you in solidarity because not only do we have a shortage of clinicians, and the shortage is going to get worse, but we have a significant challenge with burnout. And a lot of that burnout is driven by the fact that it is not a very fun experience delivering care. Not the patient to clinician part, not the actual part of like delivering the care to the patient, but all the other things around that we have to do the different administrative functions, the documentation, the death by a million clicks in the electronic health record, the fragmented technologies that don't talk to each other, the overwhelm of the information. It's not easy right now to take care of patients. And my team, we definitely want to show a commitment to our peers that we are committed to making that better, because ultimately the reason that we're here is because of the joy that we have in the connections and the relationships that we make with patients, and the ability to heal and to care for them. And we want to give our peers the empowerment and the ability to do that in the most meaningful way that we can.
What are you seeing as far as relief with your practitioners now that AI is a little bit more involved?
Well, I go back to the three examples that I gave you that we're really focused in on. And so, for example, with all three of the examples, with the Dragon Ambient experience, with Provaria, and with MedPearl, those three solutions are really trying to tackle some of those administrative burdens or challenges that we're experiencing, the cognitive overload, the overload of information, the administrative factors. And so we actually use KPIs and measurements when we're evaluating these solutions to say, like, how are we impacting that? So we know, for example, with MedPearl, that we've been able to demonstrate reduced after hours time in the charts by 2 hours a month for the clinicians who are super users. We've been able to demonstrate improved EHR, electronic health record efficiency scores for our super users. We've been able to demonstrate a self-reported, statistically significant improvement in level of confidence when they are referring patients. So when you are a brand new nurse practitioner out of training, right, and you get thrown out into primary care and you have thousands of conditions that you're responsible for, that you need to triage and then navigate patients to, being able to say, hey, with this tool, with this application, I feel more comfortable about how I'm delivering care to my patients. I feel more confident in working them up and getting them to the right place. Like, those are things that are drivers of burnout that you're addressing with technology. And then when we talk about Dragon Ambient experience with the DAX, Copilot, it's, reduced time documentation, reduced time after hours, satisfaction with the application. So those are the things that we're doing to measure both key performance indicators and also to tell the ROI story, because we obviously have to get the CFO to sign off on bringing things in. So we can't bring in all these new technologies that are just going to increase costs significantly without some type of return. And it's challenging. I mean, it's a process of trying to tell that story, of trying to explain it, measure it, and continue to support providing that solution. But as we think about bringing these things in, and then the other thing that I would say is we need to think about how these things all fit together too, right? Because what I don't want to have as a clinician is now 5 things that help me with my workflow, but they don't talk to each other, right? So we can't have a thing that helps with workflow here, and then a thing that helps with workflow here, and then a thing that helps with workflow here. And then me as a clinician, I have to go in and out of 5 different applications. We need an end-to-end solution. And then we need to be able to have friendly relationships with our electronic health record vendors so that they're supportive of integrating all of these things into that experience.
Well, yeah, and that was one of the questions that I was thinking about, is that, when you talked about the different clinicians and doctors and surgeons, and, they're all strong-minded and they have a lot of different opinions, what has been the overall reception from these different groups of people? Have they been open to embracing this generative AI, or is it been with hesitation, or do they have a voice of how it's being developed and used? What's that experience like?
Yeah, so I talked a little bit about the fact that I co-lead that clinical AI work group.
Yep.
And so I would say there's a ton of excitement from clinicians in the sense that they they see that there's kind of two camps, I would say. There's some that are purist. There are some physicians who are like, never, right? I will never use any of this stuff. I don't trust it. I won't use it. Or they're afraid of it to some extent, like this is going to replace me. I would say that that's a smaller percentage of clinicians, but there's definitely those in that camp. And there's also ones that are just completely not aware, just not even paying attention to what's going on. I mean, I'm serious. There are.
I believe you.
And then there's like some who are like, this is really interesting and has a lot of potential, and they're really thinking critically about it and thoughtfully about it, and they're curious and they're playing with it. I mean, I probably play with ChatGPT and LLMs like every day. It's just there's some of us that we want to see the potential. We want to think about the potential. We want to think about how we can start to weave it in a responsible, secure, safe way.
Yep.
But we know that it can help us. And then there's some that are just like way out there, on a spaceship going to Mars. Harvey Castro would be one of those guys. He's actually speaking at the Ai4 Conference, and he is just like, he's a delight. He's so much fun, and he is just wild. And he loves ChatGPT. So, I mean, then there's some, but the great thing about people like Harvey Castro is he's like pushing the envelope so far out there to say, guys, like getting people kind of excited about it and thinking about it. And so, I think we're all having conversations internally. I think the other thing that's really important to think about is the fact that in different specialties, different applications of AI are going to make more sense than others. So, for example, with DAX, the Dragon Ambient Experience, there's some specialties where it just might not make as much sense or be as necessary to have that type of solution available. And so they may not adopt it as much, versus other specialties, they're going to use it in every single visit. And you see that across, back in the day when we used to do dictation, and we had like transcription services with humans who would like document our notes. There were some people who used dictation for every single patient visit.
Yep.
And then there were some people who only used it for specific things. So for me, I only used it if I was going to do an operative report.
Okay.
Right? If I was doing a visit in the clinic, I just, I could usually document pretty brief notes, and I had templates and things like that made it pretty quick.
Sure.
So I didn't need a dictation service for those. So, we're all a little bit different, and we have to have some tolerance for, there's not going to be a one size fits all, and there's going to be some variability. The other thing I want to say is that it's not just about generative AI. It's not generative AI. There's other types of AI, right? There's machine learning, and it's not, AI is not just generative. And so in radiology in particular, there are already, I think it's about 800 FDA approved AI algorithms that aren't necessarily generative AI algorithms that can help facilitate and augment radiologists, pathologists, specifically more around radiology, neurology, and cardiology, around imaging interpretation or imaging interpretation support. And so, in those specialties, that's where their area of focus is going to be when we talk about like AI implementation and areas of focus.
Right. And, speaking of that specifically, an article just came out regarding Microsoft and Providence about using generative AI for digital cancer diagnosis.
Yeah.
And using the images to that they used over 1 billion images of tissue samples from more than 30,000 patients to create this. What are you seeing? Is that going to have a long-term impact on practices in helping the patient-doctor care?
Absolutely. I think pathology and radiology in particular, those are areas, and they were using, I think, computer vision for that particular project as well. And I think there's just so much tremendous promise. And I think there were folks a couple of years ago who, were saying radiologists are going to go away and there aren't going to be radiologists anymore. Well, not necessarily.
Right.
Okay. So back in the day, a pathologist had to review every pap smear that was ever done. And then now they've built cytology machines that can kind of do the pre-read, and then there's oversight and quality control of those reads. So what I envision will probably happen with radiology, especially as we expand more and more and more imaging capabilities. So we have this limited number of radiologists, right?
Yep.
They're not like expanding that number rapidly. And then we have more and more things that we can image and more ways to image them. And we're actually able to democratize imaging with handheld ultrasounds and like mobile MRIs and things like that. So as we increase the capacity of all the things that can be imaged, we have to increase the capacity of the people who interpret them. So there could be a time in the future where, chest x-rays, for example, maybe they have like a chest x-ray AI read machine that just, filters through, and then it flags the ones that are abnormal that get an, initial interpretation and an overread by a radiologist. Those are the types of things that may happen. The thing that's really important though is when something comes back that's abnormal or complex or difficult, you have to start to think about like, how do you have a conversation with the patient about their findings and talk to them about the implications of what that means? How do you collaborate with your interdisciplinary team, specifically in cancer care, when I'll just, they have these tumor boards where they'll get together and they'll bring a pathologist, a radiologist, an oncologist that does medical oncology, a surgical oncologist, and they'll come together and they'll bring all this information about a patient and come up with a care plan for that patient together in a room together. Like, that's what we need our radiologists to be doing more of, not reading normal chest x-rays, right?
That's where your input is vastly important to this process to help the technology people who are clearly can help on making all the efficiencies into the care, but you still need, your perspective and other people like you, their input to saying, whoa, like that's where that stops. Now we need the human to intervene.
Yes.
And we need that part that, I feel can't go away whatsoever.
Right.
I mean, it's supposed to complement each other, in my opinion, be one or the other.
I truly believe that AI is going to augment us. Like when I think about, when we talk about MedPearl, like what is the vision for MedPearl? What is the vision for all these technologies? It's like, we need a Jarvis for doctors.
Sure.
Right?
Sure.
I mean, we need our Iron Man suit. No, but I mean, really, like, we still need to be in the driver's seat.
100%.
We still need to be making the decisions. We still need to be driving forward, but we have all these promises of technology to augment us and make us better. I mean, in surgical care in particular as well, because I told you I was a robotic surgeon, and, I operated for years. I managed a team of we had over 40 surgeons in my team when I was at Common Spirit. And then I had surgeons from other surgical specialties. And there's just a dramatic amount of variability in surgical techniques, surgical outcomes, efficiency, time, equipment use. All of that is an insights, data, understanding what is driving that variation, and then aligning around best practices. All of that is like a data issue and an information issue, and the information is out there. It's just not like put together in a meaningful way to help us improve the care delivery process. And AI, there's all these like technology AI platforms that are coming out there that are starting to look at this, like, how do we think of surgeons as professional sports athletes, right? Where we can do video playback, we can get analytics on their surgical techniques, we can give them feedback on how to improve their surgical techniques.
Oh, wow.
We should be able to do that, right?
That
We do that in professional sports.
Sure.
Why don't we do that with surgeons? And so there's like these platforms that are coming out that are starting to do that. And I'm like cheering them on because I, one of the biggest struggles I would have is I had a surgeon who took 2 times as long in the OR to do a surgery, drove the anesthesiologist crazy. Like, knew that they were taking more time, but we didn't have like a great mechanism to give them the feedback on how to improve their care, or maybe didn't have as good of outcomes as their peers. How do I give them that feedback in a meaningful, non-subjective way? Because it's very subjective. It's like peer-to-peer, opinion driven. And it's like, how do I give it to them in a non-subjective way? And we have great data out there, both in video, imaging, like just, because a lot of surgery, especially the surgery I did, is video assisted surgery where we'd have cameras and things like that. So all of the data is there. We just need to be able to package it up and serve it up to the surgeons in a meaningful way, and have the right clinical leadership and sponsorship in place to drive it forward.
That's very interesting. I almost could see that like being a documentary show. What's the process and evaluation of how people are doing in different hospitals? But I don't know if anybody would want to subject themselves to that kind of scrutiny either. So that would be very interesting. But when you are speaking at the Ai4 Conference in Las Vegas, August 12th through the 14th at the MGM, you mentioned a couple of people that you're looking forward to listening to or meeting or seeing there. There's over 5,000 people going. Who else are you on the attendee or speaker list that you are excited to see?
I'm going to go see my buddy Harvey Castro, of course, because he's just like one to watch. Crystal Broge is going to be there from Medical University of South Carolina. We have a close relationship with them, and I'm excited to see her speak. I don't know that much about any of the cross-industry speakers. So one of the things that I really love about the Ai4 conference, which sort of fell into it randomly last year. I don't know, like they reached out, asked if I wanted to go and speak, and so kind of fell into it. But what I found really surprising, number one, it was literally, you could barely walk through the halls because it was so crowded and they were so oversubscribed on attendance, which is a testament to how interested people are in this conference. I'm just really excited to learn about some of the other things that they're doing in other industries and how they're looking at AI and how they're looking at applying it within their industry. So for education or banking or, defense, there's like different industry pillars. And I think it's really good for us to have some of that cross-pollination and learnings across the industry. When I did the panel last year, there was somebody from, I think it was from the banking industry on my panel, and then there was somebody from marketing as well. And so, we had like 3 different industries represented, and I thought, how is this going to go? Like, what are we going to talk about? And it was a great conversation.
That's
and we
awesome.
actually had some really great things that we could share with each other and learn from each other about how we're approaching it.
That's great.
I think everybody's kind of struggling, with like how to like keep up and figure all of this stuff out.
Yeah, absolutely. Now, what's a topic that you're going to be covering at the show?
Yeah, we're going to be covering diagnostics, so leveraging AI for diagnostics. And, I'll talk about MedPearl and how we're leveraging that. I'll also talk about our journey at Providence of, we would love to bring AI-assisted solutions for radiologists into the health system. Even with the technology existing and being out there, it doesn't necessarily mean it's something that you can easily bring into your system. You have to have sometimes there's integration considerations, there's infrastructure related considerations, and there's workflow considerations. And then how are you going to pay for it, right?
Right.
So, even though there might be a strong desire for X to come into the system, the actual process of bringing that in is not always an easy thing to navigate through, and it takes time.
Sure. And then, I've gone to different conferences, listened to different speakers. Sometimes it's more educational. Sometimes it's more entertainment. Sometimes it's just a discovery of what they're working on within their field. What would you say, you would like people to take away from attending, your segment in particular at the conference? Like, what do you hope is the key takeaways that people understand?
I think the key takeaway is that, the clinician community and the physician community in particular, there is a lot of interest in this technology. There's a lot of desire to, everybody kind of knows, not only, I talked about the fact that like delivering care as a physician isn't always an enjoyable experience. It's not always enjoyable for patients either.
Sure.
You know, I mean, why do you have to spend 20 minutes on the telephone making an appointment still in many health systems today, right?
Right.
Why? Remember the days of banking when you had to go to the teller and like cash your check? And like, that's kind of where we're at in a lot of places in healthcare. And so how do we create that, you know, app-based, mostly patient experience where you're really only like connecting to the banker or to the clinician when you just can't get the answer to your question, or you can't get what you need through that digital interaction. And so I think, you know, there's some things that are just, they're not necessarily AI, they're just digital transformation opportunities. But then the AI on top of that, I think is going to make that even a more impactful experience. And so I think the takeaway is that like we're committed to moving in that direction. And these are the incremental wins that we've had. And this is kind of how we're looking at it. But then, you know, also to help people understand that it's going to take time. You know, it's going to be messy for a couple of years, maybe a decade even, as we navigate through this. It's not a simple turn the lights on thing. It's going to take time, and there's going to be things that we'll have to sunset too because they weren't successful.
Sure.
And so, you know, we have to be patient as we move through that process.
Which totally makes sense. And again, that's August 12th through the 14th, the Ai4 Conference in Las Vegas at the MGM Grand. And if you don't have your ticket yet, or you would like to attend, of course, you can go right online to Ai4.io and learn a lot more about all the speakers that are going to be there and attendees. And there's a great valuable information. And like you said, there was like shoulder to shoulder last year when you were there attending. So that, which is great to see the buzz. And I know that this year will be even bigger and better, and I'm excited. Now we are coming to the part of our show where we call it Fast 5 with AI, and how it works is that ChatGPT is going to ask you 5 rapid fire questions. You give short answers. One, you know, we always say one word, and then nobody follows the rules. So 1 to 5 words. Answers. She's ready to, you know, fire away our brand new segment, Fast 5 with AI.
All right, here we go. Favorite AI-powered app?
Copilot.
One word to describe AI's future.
Bright.
Love it. Favorite AI feature in daily life?
I keep thinking Copilot. I use Copilot like all day long.
Everything. All right.
Not for patient stuff, but for my administrative work.
All right. Fourth one, AI's biggest challenge in one word.
Trust.
That's a good one. Okay, one non-AI question. Beach or mountain?
Beach.
Yeah, I agree.
All right, as a parent, have you ever used Copilot to ask parenting questions?
No.
No, okay.
No.
All right.
I really do. I use Copilot to, you know, when we're having meetings, I have a lot of meetings.
Sure.
And we turn it on, and I don't have to have somebody taking notes.
Right.
So I think it really like creates like a relief for the people who are on the call, where they're not having to like, you know, take down notes, that they actually can really engage and pay attention. So it actually improves, I would say, the engagement and the communication during the meetings.
Yeah.
And then AI kind of does, you know, Copilot does the work, recaps the meeting, sums it up. So that's probably one of the biggest things that we use it for. We also, I use Copilot to help find things for me. So, you know, and I was thinking about this before the podcast. I actually think our whole concept of search is just going to completely evolve and change. Like, Google is not going to be where we go to search things, or, you know, Bing or whatever it is. It's going to be, we're going to have these AI assistants, and they are going to be our search engines for us.
Correct. Right.
In the sense that, like, we're going to leverage and we're going to use it for querying. So right now, if I go to Google, I search, and then I get a list of websites. I got to go into each website and, pull things out. And
That's
now, once we're trusting the technology enough, right now it's for basic things that I'm using it to help filter and search for me. But I think going into the future, it's going to be like, hey, I need a doctor who does knee surgery for my 68-year-old, mom. She needs a knee replacement. Who's the best one in this town with the best star ratings and has access, pretty quick.
Right.
And takes my insurance.
Yep.
And it's going to spit it out for you. And that's how people are going to search for things.
Yeah, it will be a beautiful thing when it happens to that level. Absolutely.
Yeah.
Because then you're getting the personalized results that are just tailored to your specific needs and not such a broad on the definition of the keywords you're using.
Because right now, if you search, then you're just going to get a list, and then it's like the person who paid the most money. I guess I kind of wonder how SEO is going to evolve, though, with all of this.
Right.
Because it's like the person who comes to the top of the list is like the one who, optimized their SEO. Like, how are they going to do that with the AI search functions? I'm very curious. There's going to be a whole other mechanism of commerce in that industry.
Well, it'll be interesting because, like you said, when you gave that example, you were saying based off of the reviews, based off of your insurance needs, and whether you're buying something on Amazon or you're going on Google and you're looking for a business in a particular industry, you look at the reviews. So if the AI is doing that for you and just giving you the one with the best reviews, then I guess you don't have to go through all the searching and all the time and energy to find that information. So it will be probably most likely based upon how the criteria that's important to you. And
it's your prompt.
Yeah.
Right.
Yep.
It's your prompt. But my question is that going to completely disrupt the search engine optimization industry? Like, how is that going to impact that industry? Right?
I think it will. I don't see how it won't. It will just come down to the information that you have on your site or whatever that you can plug into the AI to make it as AI friendly as possible. That will be the most important. But yeah, absolutely.
But knowing that humans are going to have different particular customizations to the information that they want to serve up to themselves. Like, it's not going to be as simple as the way that they map SEO. They have to think about how different individuals are going to weight these things and want to prompt these things. So it's going to be really interesting how the marketing industry tackles that problem.
It will.
Not my problem to solve.
No, I don't think we're going to solve it right now. But I do appreciate you coming on the show. We're almost out of time. I would like to end on a final thought for the podcast. What would be one key takeaway that you hope people who are listening or watching on YouTube today, what do you want them to take away from this conversation about what you guys are doing at Providence?
Yeah, I think the big takeaway is just we're really committed to restoring the joy in delivering care for our clinicians and restoring peace, comfort, and joy. At times joy, sometimes it's just peace and comfort and addressing the needs of our patients. So really maximizing the ability for our clinical workforce, our clinical facilities, our clinical capabilities to provide the best care that we possibly can across our populations. And so that is our mission, is to serve poor and vulnerable populations, to serve as many patients as we can, and to deliver really high quality care.
That's great. Well, thank you very much for coming on the show today. And for those people who are listening or watching, you can always find us on the socials. So we are on Instagram at askClever. On Facebook, we're at facebook.com/askClever. On TikTok, we are at askClever-Over-Coffee-Podcast. And on YouTube, we are also at askClever-Over-Coffee-Podcast. And if you want us to connect with either one of us, we're definitely available on LinkedIn as well. And we will put all the links in the comment sections below. But we really appreciate you guys tuning in and listening today. And hopefully you found a lot more about what is truly happening with AI on healthcare, and we answer some questions that you might have. And of course, if you do have follow-up questions to the show, feel free to leave a comment or, search us out on social media, because we'd love to hear from you. So thank you again for listening and tuning in, and so long and farewell.